Hi everyone, this is Karen Moldovan with the Colorado Coalition Against Sexual Assault. And with me I have Terry Livermore, who is with the Division of Criminal Justice Office for Victim Programs. So Terry, I don't know if you wanted to give a quick introduction.
Hi, I'm Terry Livermore. I work in the Office of Victim Programs, as Karen said, at the Division of Criminal Justice. I manage a sexual assault response project throughout Colorado to develop medical forensic exams and SART teams, mostly in rural Colorado. And then we partner with CCASA on a number of policies.
Unmuted.
One of the things, the issue that we'll be addressing today.
Great, thanks. All right, let's go ahead and get started. So I think most of you who are on the webinar are probably at least a little bit familiar with the Colorado Coalition Against Sexual Assault, or CCASA as we call ourselves, but we are a statewide membership organization working on safety, justice, and healing for survivors while working to eliminate sexual violence. And our role is essentially the umbrella organization for our member programs. We have a wide array of members, everything from community-based advocacy to law enforcement-based victim advocacy, campus programs, SANE programs. So we have a wide array of allies who are doing this work, and our job is really to provide training, technical assistance, publications, and public policy representation for our member programs. So we're going to talk this afternoon about a bill in particular that I think you all are at least somewhat familiar with, and that's Senate Bill 128. So that's a bill that CCASA worked on with many different state partners. It really had been sort of in the works for a few years before we were able to bring it forward as legislation. So really the purpose of this webinar is to give some background on Senate Bill 128 and talk about what it means in terms of implementation and to get a sense of where folks are, because this bill does change practice for both law enforcement and medical providers, and we really see it as a more victim-centered approach to making sure victims are able to get their medical needs attended to and met. So folks, I think you do know that there is a question box, so we'll be keeping an eye on the questions throughout the training. We are going to kind of give an overview of the bill and then walk through some scenarios where we give you some samples, of a patient seeking care and talk about, what sort of mandatory reporting obligation may be in place, what isn't required to report, and how Senate Bill 128 may have affected some of the patient care options. So we'll sort of wrap up with some scenarios, but you can type in any questions at any time.
I'm going to go ahead and start by giving a little background on how we ended up here. But before I do that, I should also mention that Karen, my co-presenter today, this is actually her last day at CCASA. This is, in fact, the very last thing she's doing at CCASA. So we certainly appreciate her doing that today. But on a personal and professional level, I think the state is truly going to miss Karen. We wish her well in her new job. But a little webinar round of applause for Karen. And then also, I wanted to let you know that because I believe both our contact information is at the back of this, but you can just go ahead and draw a little line through hers. So if you have any questions, certainly in the immediate future until CCASA is able to fill this position, go ahead and send your questions to me or give me a call. And my contact information is at the back. So how we got here is in 2005, the federal government passed a law that said if states want to keep getting federal dollars to help victims, they're going to have to allow sex assault victims to get a medical forensic exam with evidence collection without having to participate with law enforcement. This is the beginning of a change in philosophy with sex assault victims. I think people began to realize that what we were doing really wasn't working very well, and it was still a massively underreported crime. And victims, as a result of not having the best of experiences or not choosing to engage with the criminal justice system, we're also not getting medical care, critical medical care. And so we being the entire field, started looking around and saying, what is it we can do differently? What we're doing isn't working, we need to do something differently. So this is one of the early steps in that, to say, let's start giving victims choices and options. And one of those options is going to be get them to medical care so they can get appropriate medical care, and then they can, if they want, they can have evidence collected. And if they want to have evidence collected, but they don't have to engage, at least immediately, certainly with law enforcement, and they get to make that choice. So that happened in 2005. The federal government gave states 3 years to pass a corresponding law, and Colorado passed ours in 2008. That law basically says that victims can get a medical forensic exam. They do not have to participate with law enforcement, and that law enforcement will store those evidence kits for a minimum of 2 years. The other thing also recently passed to facilitate this was CCASA passed in 2013 the SAVE bill. It's Sex Assault Victim Emergency Fund program. As we all know, victims who report to law enforcement have access or are eligible for victim compensation to cover a wide range of costs that occur to them as a result of the crime. Medical reporting victims, which is what we've termed these victims who get medical forensic exams, have evidence collected, but don't engage with law enforcement, at least initially, we've termed them medical reporting victims. Medical reporting victims have no access to other funds to help them. And while the evidence collection part of the exam was free, getting it was not. Hospitals can be expensive. To walk through the door of an emergency department room typically costs money. CCASA recognized this as an issue and in 2013 passed a law creating the Sex Assault Victim Emergency Fund program. That pays for the costs associated with victims getting the medical forensic exam, and also if there's room under the cap, which is right now $3,000 per victim, if there's room under that cap, then we can help cover any medical costs for injuries that occurred as a result of the crime. It's not at all comparable to victim compensation in terms of the capped amount and what it covers, but it does enable a lot of victims who wouldn't otherwise be able to afford to get a medical forensic exam the ability to do that. That is administered through my office, so if you have any questions about the SAVE program, feel free to give me a call or send me an email. So that was where we landed. Then in 2011, we said, let's take a look. We passed the law in 2008. Let's take a look and see what's happening in Colorado as a result of it's called forensic compliance. It's a horrible name. It's what the feds called it. We've decided to embrace it. And so we created, CCASA and DCJ jointly created the Forensic Compliance Evaluation Team. This team took a look and said, we want to find out what's going on in the state. So we created this project, a research project. We created a multidisciplinary stakeholder group. We developed a survey. We did a research project on the kits that were in our office. That report is available on CCASA's website. You just have to Google Forensic Compliance Project and CCASA and you'll get the report. It covered a number of things. Today we're just going to address, a couple of the items that we talked about. But what we did was take a look at what was happening in the state and to identify gaps and training issues and those kinds of items. We surveyed a number of people. We sent it far and wide. We got 239 responses, which is a pretty high response rate for surveys of that nature. And interestingly, our highest responding group were law enforcement. Very unusual, but they were definitely the highest responding group, which indicated that they had a lot to say about this issue. The two issues that were part of this survey that we're going to address specifically that led us to Senate Bill 128 are two questions that we asked. One, we asked, had any of the people responding to the survey ever encountered a victim who wanted to remain anonymous, who wanted to maybe report or get evidence collected or whatever, but wanted to remain anonymous. And over half of all respondents had encountered at least one victim who said that. We thought that was statistically significant simply because anonymous reporting is not an option in Colorado. We're only one of 9 states that mandates medical mandated reporting. And so to ask to remain anonymous when we don't have that option, we thought was relatively significant. The other question we asked about was medical mandated reporting. Do people know about it? What do they think about it? Do they support it? And what are their thoughts on it? We allowed a comment area, which I'm very happy we did because we found strong support, interestingly, across all responding agencies, responding entities, even advocates, which surprised us, quite frankly. But what we also found was there's tremendous confusion about the medical mandated reporting law. It didn't take long to start reading the comments to realize people were very confused about what that meant and how it affected them. And so what we realized is that we've had an issue with anonymous reporting and we also had an issue with medical mandated reporting. And so we wanted to take a look at those in particular and see what we needed to do about those. Again, the one thing I wanted to say is anonymous reporting, the reason we asked about it actually was because we recognize one of the barriers to victims coming in to get medical care is that they are afraid of being reported on. Again, we're a medical mandated reporting state, and I think they were afraid for all the reasons that we all know. They don't think they're going to be believed. They don't want to identify the offender. They're embarrassed of their own activities or what they perceive to be their own participation in their assault. We all know none of that is accurate, but that's that's how victims tend to react to sex assault. And so our goal is to remove barriers so, again, victims get medical care, and in doing so, get contact with the support system, and hopefully for those that it works for, then report the crime so we can then pursue the offenders. Counterintuitively, we have learned nationally that when we create options for victims, when we allow them to remain anonymous, when we allow them to go at their own pace, reports tend to go up. Law enforcement reports tend to go up. This is part of the change that happened in philosophy with sex assault victims. If we give them more choices, we give them more options, and we let them direct their own opportunities around reporting and receiving care and obtaining care, that more of them will tend to engage with the criminal justice system and stay engaged with the criminal justice system. We're at the front edge of studies on this, but the early results, I would say, are very promising. This is also important because it gives us an opportunity to ID serial offenders, and it also has led to more successful prosecutions because the cases that get put together early are better. Again, we're in the early parts of these, but it's promising, I would say.
Okay, so, as Terry talked about, Senate Bill 128 it came from a lot of concerted work at both the state and the federal level around increasing a victim-centered response and making sure that victims are able to access what they define that they need. So that's sort of where Senate Bill 128 was born out of. And as Terry mentioned in the survey, we asked about the specific statutes. So you guys have the citation at the top of your screen. It's that Colorado Revised Statute 12-36-135, and that's where this whole issue of medical mandated reporting lives in Colorado statutes. And I just want to mention that this statute around medical mandated reporting is different than other mandatory reporting obligations that may exist for minors or elders in the state. So, this statute is talking about really what happens if competent adults come in for health care and the medical professional believes that they have injuries due to a crime. So in our survey, we asked folks what they thought about this statute, and that's where, people generally liked the concept, but there was a lot of confusion about what the statute actually says and what it meant. So Senate Bill 128 was really, the goal was to, number one, address this anonymous reporting gap that we were hearing about so that victims had that option if it was right for them. And number two, to try and clarify this medical mandated reporting obligation specifically for sex assault. So this statute is written for all types of crimes. Clearly, as the Colorado Coalition Against Sexual Assault, our purview wasn't to change how medical professionals responded to a gunshot wound, for example, or any other crime, frankly, but we did feel that we could help clarify it in terms of sex assault. So what you have on the screen is just the basics of what this statute did prior to Senate Bill 128. So what it said is that a medical licensee must report to law enforcement treatments of injuries believed to be caused by a crime. And the type of crimes required to report are listed in the statute. So, it literally says, for example, gunshot wound, stab wound, dangerous dog bite is in there. But then it also has this sort of umbrella statement that says, they must also report, domestic violence or treatment of injuries believed to be caused by a criminal act. So it's, they're enumerated, but then it also says really any treatment of injuries caused by a criminal act. So with this slide, there's actually a lot to unpack that I think is important for sort of understanding what it said, so folks have a sense of the changes that have been made. The first thing that I think is really important for folks to notice is who is defined as a licensee in this statute. So this statute is only written and only applicable to physicians, physician's assistants, and anesthesiologist assistants. That's it. So I think there's been a lot of confusion over the years about that, who the statute even applies to. This is not, this really isn't ambiguous or vague in the statute. This is very, very clear that, that these are the three entities that are covered under this statute. So I think that's important for folks to think about. But, I'll say that, that this statute in general always sort of made some medical professionals a little uncomfortable because we would hear from medical professionals that that really felt that their primary role was to provide health care and patient care, and it wasn't really their job to investigate or determine criminal activity. So this whole, saying that the medical professional needs to report what they believe was caused by a crime, for some medical professionals, that felt really uncomfortable all along because they didn't feel that they were trained to determine what was caused by a crime or not. So, I just wanted to mention that this was, while there was a lot of confusion around even who this statute applied to and what it meant, there were a lot of folks who really didn't even feel all that comfortable with the basic concept of it. And that was sort of compounded by the fact that Colorado is only one of 9 states that has this type of requirement that applies to competent adults. Most states, if every state has a mandatory reporting obligation for child abuse, Colorado does. I think we all intellectually understand why we need laws to protect minors. Most states have similar laws for at-risk elders or people with intellectual developmental disabilities. But this type of law is pretty unique because it applies to competent adults who are seeking health care, essentially. And really what we know is that nationally, best practice is really to provide victim choice regarding law enforcement interactions and when and how that happens. So, requiring this sort of interaction for an adult seeking health care was challenging to some people philosophically anyway. So, we talked about licensee, and the thing that was tricky is that, just to put it out there, nurses statutorily were never covered by this statute. In Colorado, nurses widely, though, were trained that this statute did apply to them. And I will be the first to say that what's in statute and law may be very different than what's in hospital policies. So nurses may have a hospital policy that says they need to report injuries to law enforcement that are believed to be caused by a crime, but legally and statutorily, that obligation, it's just simply not a part of Colorado's law. So I think, that was always sort of a tricky and important distinction that folks weren't always making. And then oddly enough, something else we found, that term injury, that seems pretty black and white and straightforward, right? If you believe an injury is caused by a crime, you report it. Well, we were hearing was a wide interpretation of what injury even meant. And, you could talk to one medical provider who would say, injury to me, that can mean anything. That can be emotional injury. So you could talk to one medical provider who was on really one spectrum of it, defining injury. And then I remember talking to another medical professional who said, well, I interpret that to mean serious bodily injury, or, SBI, which is an entirely different, extremely high threshold, and, exactly what it says, essentially a life-threatening injury. So even that term caused some confusion. So that's the statute that we were dealing with. And because of sort of all of these challenges, we felt that it was really important to revise the statute. So we had all this survey data, as Terry mentioned. We had 239 multidisciplinary professionals around the state where we asked them about this statute, as well as anonymous reporting. So we had a lot of data to look at, and a lot of people, wrote in their comments and feedback. And then we met with, spent some serious time meeting with stakeholders. So probably for over a year, CCASA and DCJ on some level, we met with the Police Chief Association, the Sheriff's Association, the District Attorney's Council, certainly the Sex Assault Nurse Examiner Advisory Board, the Colorado Hospital Association, talked to victim advocates, CCASA members about it. So we did a lot of stakeholder work, before we jumped into this revision process. And then collaboratively, the Forensic Compliance Team and the CCASA Public Policy Committee started to meet with some legislators who were interested in clarifying the statute, and started looking at, how can we at least make this a little bit more clear for sex assault? So as I mentioned before, it really wasn't our purview to determine what happens when there's other injuries caused, believed to be caused by a crime. And some of our stakeholders were like, if you're going to do this for sex assault, then we need to get rid of, or we need to change, or, clarify medical mandated reporting for every type of potential crime, and that just wasn't our purview. CCASA shouldn't be in the role of determining what happens when a patient presents with a gunshot wound. That would require a lot more stakeholder work that wouldn't necessarily be appropriate for us to convene. So while we did clarify sex assault, we know that there are situations in which sex assaults and other injuries and other crimes are intertwined. I will say the majority of sex assault cases, there actually are not other injuries, which surprises a lot of folks who don't do this work, and we could go on and on about perpetrators and how we know that perpetrators of sexual violence use what we call, it's a term called instrumental violence, where they'll use sort of the smallest amount of coercion or pressure possible to obtain compliance. So, if you can threaten somebody saying you'll lose your job if you don't do this, or I'll ruin your reputation, then why pull a gun type of thing. So, there's a lot of factors why that is, but most sex assault patients don't have other injuries. However, we certainly recognize that there will be cases, right, where it's a sex assault patient, but then there also could be a stabbing, there could be a gunshot wound, there could be a concussion. So when our scenarios, when we get to that, we are going to talk about, we recognize this is pretty clear for sex assault, but when there's other crimes and injuries intertwined, it can be a little bit more challenging. Okay, so the overarching goal of the statutory revision, Terry talked a little bit about this, and I guess I just want to say, why is it that we decided to take this up and spend so much time trying to figure out the statute? And really the reason why we dedicated a lot of our resources to this issue is the reality that sex assault is the most underreported crime in the United States. Victims don't come forward, they don't get medical care, they don't learn about their law enforcement reporting options, and when that happens, we know that victims are more likely to have long-term post-traumatic stress, long-term mental health problems, and we know that perpetrators aren't held accountable. We know that victims have, in terms of mental health issues, when they don't seek help. We also know that there's long and short-term health consequences as well, as a result of not getting services following a sex assault. So really this effort was a part of a much broader, as Terry said, sort of national effort to give adult sex assault victims more choices and options. And we know that when victims have more choices and options, they tend to use them and tend to engage if it's put on their terms and their time and their level. And that's particularly important with sex assault because, that's a crime that really removes power and control from the victim. So if we can say, here on out, you decide what happens, you decide how it happens and that timeline and who you talk to when and what information you share when, that can be extremely important for sex assault victims in particular. So all of that is sort of some of the background and why we decided to look at this issue. And the reality is we also know that sex assault perpetrators, they often target victims who are vulnerable, accessible, or lacking in credibility. So, these are oftentimes the victims who are the most likely to fear law enforcement interaction. So victims who are undocumented, victims who were, using illegal drugs at the time of the assault, all of those things that you all know. But we all know those victims still need and deserve medical attention. And, with this revision, hopefully victims who maybe are afraid of law enforcement, they're now able to access, critical medical attention and support and then start to learn about those law enforcement options on their own terms. I said this already, but I just think it's really important because I still get a lot of questions about this. With Senate Bill 128, we did not change any other mandatory reporting requirement that's in statute. So I just want folks to definitely know that because we could, sort of continue to get asked, how this applies to minors and how this applies to elders. There was a bill that passed this legislative session that starting in 2016, there will be a mandatory reporting requirement for adults with intellectual or developmental disabilities. And this bill did not change any of that. If there was a mandatory reporting obligation for that population, it still stands. But because of those obligations, it's important to know that evidence really can't be stored anonymously because those other mandatory reporting statutes require a report to law enforcement with victim identifying information. So that anonymity is really, anonymity at the time of evidence collection is really only an option for competent adult victims. Okay, so now we are going to talk about what are the changes under Senate Bill 128. So the way that I like to think about this is Senate Bill 128 essentially created two categories of victims. And that is around evidence collection. So you have two categories of victims. On the left side of the screen, you have a victim who requests and has evidence collected. So if there's evidence collected, there's going to be a report to law enforcement. There just is, if there's evidence collected. And just think about, if there's evidence collected, then you actually have a physical rape kit. And in Colorado, law enforcement stores that evidence. It may be tested, it may just be stored depending on what the patient, the victim wants. But if there's evidence, law enforcement is going to be involved, because in order to maintain chain of custody, it has to go to them. It's not going to stay in the nurse's locker or go home with the victim. So you have victims who have evidence collected, and then you have victims who don't have evidence collected. So victims who are having evidence collected, there will be a report made to law enforcement. The type of report made to law enforcement is 100% up to the victim, and we're going to walk through what that can look like. If a victim's not having evidence collected, then typically there's not a report that's going to be made unless, so you have it on your screen, there's always some caveats because we have other related laws. But if a licensee, and we talked about that, as defined in statute, treats or attends to injuries that they believe have been caused by a crime, or if there's other mandatory reporting statutes, then a report is going to be made in those situations as well. So we're going to deconstruct these a little bit more. So looking at what was on the left column, so victims who have evidence collected, clearly law enforcement is going to be involved on some level. Victims now have three choices. So, if a patient comes in, they want evidence collected, then really what the conversation needs to be, okay, that's, you certainly can have evidence collected. It's up to you if you want it tested or stored. And it's up to you what type of report you want to make. So the victim can make a law enforcement report, and that's the option that's, always, existed under Colorado law, essentially, where that's where the victim is choosing to work with law enforcement at the time of medical care, at the time of evidence collection. They want to engage in the criminal justice system. So that's one choice the victim has. The second choice was created in 2008, as Terry talked about. So this is a medical report. So this is where a victim, wants evidence collected, but maybe he or she just isn't sure about this whole criminal justice thing yet. They don't know what that means. They have some anxiety about that. Maybe they have safety concerns about that. Maybe they want to talk to their friends or family first before they make that decision. So we've had that option since 2008. A victim can have the evidence collected. It's paid for at no cost to them. And they don't have to participate in the criminal justice system, but that evidence is given to law enforcement with the patient's name on it, using the victim's name. So that's how it's tracked. By the victim's name. And typically in that situation, we have been seeing, really dependent on the community, but a lot of times law enforcement maybe was still talking or interviewing a medical reporting victim, even though they weren't participating. Now, under Senate Bill 128, there's now a third option that's created for victims. So this, I don't think every victim is going to want or need this option, but this really could provide a lot of support or assistance to a victim who wants the medical forensic exam, but is just really afraid to move forward. Again, it could be safety concerns. It could be, maybe they've had a prior negative interaction with law enforcement. Maybe they're afraid they're going to get in trouble with something. Maybe they are law enforcement as a victim. Maybe the perpetrator is law enforcement. Maybe their dad works for law enforcement. Who knows? There's a lot of reasons, though, why a patient at that time and at that acute trauma level, right after a sex assault, may not be ready to give their name over or have evidence stored under their name. So anonymous reporting, it's actually very simple and very similar to medical reporting, which we've had since 2008. Really, the only difference is that the evidence is not stored under the victim's name. It's stored by a unique identifying tracking number, and we'll talk a little bit about that. And the other difference is that if it's an anonymous reporting victim, then the evidence is simply stored by local law enforcement. The victim doesn't have the option of having it tested or having it sent to CBI. Certainly if the victim decides that they do want to give their name or they do want to engage in the criminal justice system, then they can take steps to consent to having that evidence tested. But as an anonymous reporting victim, the evidence is just for storage only at that point, while there's still anonymity. And Really, the reason behind that is that with evidence testing, sometimes there's issues and questions that come up where the victim needs to be contacted, and you can't do that if they're anonymous. So those are the only differences. The medical reporting that we've had since 2008. You know, the evidence is stored by a tracking number and no ability to have it tested at that time.
With regard to the unique identifying number, we've had some questions come up about this, and I think the concern has been, well, how is the victim going to remember that? I mean, it's got to be something the victim can remember. So communities have been trying to devise a way for that to happen. It doesn't really have to be that way, for the simple reason that when they get discharged from the hospital, they'll have, or wherever they're being seen, they'll have their consent form, which will have the unique identifying number on it. Also, the medical record at the hospital or whatever entity is seeing it will have both obviously their name and then their unique identifying number. So if a victim loses their paperwork or doesn't remember it, they can always contact the medical facility and get their medical record, which would have the number. So there's no real reason to create a number that is memorable to the victim. We did have one agency who was thinking about using a victim's social security number. That's a bad idea for a number of reasons. Any number that has any identification to the victim should not be used. An email address, anything like that shouldn't be used as a unique identifying number. It should be truly unique and have no relation to that victim. I think what most agencies are coming down to is essentially using the case number. Law enforcement database systems are already set up to have those numbers input. So you can just use the number, and if your system requires a name to be put in there, figure out how you're going to Jane Doe 1 or whatever it is you're going to do in the name section. But the case number is a unique identifying number, and that's already given to the victim and has been for years. So that's probably the easiest solution. But the point is, it doesn't have to be memorable to the victim. There are ways for the victim to access it, and it just needs to be unique and have no relationship to the victim at all. So those are the questions we've had. You could do a date type number, something with a date on it. Just a pure random number, but the whole point is to not have it be at all identifiable or connected to the victim in any way.
This is Karen, and we'll just add that when we did the initial forensic compliance survey in 2011, we sort of hypothetically asked, you know, because we had heard a lot of success about anonymous reporting in other states, so we were curious, is this something that could work in Colorado? So when we surveyed folks at that time, we asked only the law enforcement respondents, you know, hypothetically, could you store evidence using a unique identifying number instead of a victim's name? And 100% responded yes, that they could. So I just wanted to point that out as well, that we did sort of ask that in the survey and talk to sheriffs and police about that capacity. And at that time, never received any pushback at all. People really said it would be no problem. So just FYI on that piece. Okay, so something else. So we just walked through, you know, for victims that are having evidence collected, they have 3 reporting options: law enforcement, medical, anonymous report. So that was one thing that was changed under Senate Bill 128. Something else that was changed under Senate Bill 128 is this whole role of nurses, because that whole question that we kept on hearing is, you know, everybody thought that the statute applied to nurses. The reality is that it doesn't, it didn't. But we did recognize that in Colorado, nurses are who are primarily responsible for sexual assault evidence collection and patient care in our state. So for that reason, nurses were added to the statute as mandatory reporters, but only for sexual assault patient care with evidence collection. So we didn't change, you know, nurses, any other nurse obligations. We just said that, you know, if there's evidence being collected and it's a nurse doing it, then the nurse needs to report it to law enforcement, which totally makes sense, because like I said, that evidence has to go to law enforcement somehow. The nurse isn't going to take it home with her for the night. So that was sort of why we made that clarification, but that's the only place in the statute that nurses are statutorily bound to report, and in that sex assault with evidence collection. They may have hospital policies that say they need to report other things, but in terms of what's legally, you know, statutorily binding, that's it. It's sex assault with evidence collection. Okay, so we covered what happens for sex assault patients with evidence collection. and the role of nurses for that. So now I want to talk about victims who don't have evidence collected. And that certainly happens. You know, we know a lot of patients maybe just are not at a place where they can even think about criminal justice involvement or evidence collection. They're just there because they want to make sure, you know, that they're medically okay, or that they didn't get an STI, or for pregnancy prophylaxis, that sort of thing. That's very common with sex assault. So what this bill did clarify, so for cases in which a patient receives sex assault medical care but no evidence collection, then a sexual assault report is not required to be made to law enforcement. You know, so it doesn't mean that nothing happens in terms of addressing the sex assault. It doesn't mean that you know, a report can't be made. It just means that a licensee isn't required to report it, and that really a competent adult patient who's seeking medical care should be able to make their own decision about discussing something that intimate and personal and private. You know, a lot of times we see these are delayed cases where it's maybe 3 weeks later and the victim just wants to make sure she doesn't have an STI, and really that's the reason that you know, she or he is there. So we really see this as sort of a victim-centered response. But I also want to say, we'll send it out afterwards, that when Salazar was the Attorney General, he did in 2003 issue a formal opinion regarding interpretation of this statute, and what saying, you know, essentially putting into the revision or the clarification of the law that you know, if somebody's just getting patient care, then a report isn't required to be made to law enforcement. You know, that's consistent with previous interpretations of what the statute always said, because the statute was always about treating injuries. You know, and if somebody is simply getting routine medical care, that's not the same as having injuries treated. Okay, sorry, we were just looking at a question that came in.
It was regarding the unique ID, and for some agencies, someone has said that they're using the incident number in it, you know, rather than the case number. So, which again, good solution. I mean, I think it's important. And I didn't say what I should have said was, it's important that communities work this out together. It has to be workable for law enforcement and understandable in general, but it's really what law enforcement feels will be a unique identifying number that their system will handle in a way that makes sense to that community. So whatever it is, we support, as long as it doesn't have any identifying type information for the victim. So incident number is another option in addition to case number.
Okay, thanks. So yeah, so essentially what that sort of leaves us with, it, we're going to move into the scenarios right now to sort of talk through this. But, you know, as we're looking at the scenarios, you know, keep in mind, again, what we talked about, the statutory definition of licensees, and that we didn't change licensees' mandatory reporting obligations for treatment of injuries, essentially. We only made a clarification specific for sex assault. So we're going to look at some scenarios. And hopefully folks will really use their chat box now, because we're going to ask you what you think about this. So I definitely, you know, want to start by saying that neither Terry or I are lawyers. We're not attorneys, so we can't give legal advice. And that absolutely hospital and clinic policies are going to vary on all of this, but we're just telling you what the law says. Neither one of us are attorneys, but I will say that we met with the bill drafter, who's an attorney, as well as Terry consulted with a judge around this. And so we did talk to a few different lawyers and gave them these scenarios as well, to sort of see, to make sure that our interpretation was the same as folks who can practice law. And certainly their interpretation is consistent with our interpretation. So we feel good about that. Okay, so what we're going to do is ask you to type in your answer in the text box. So here's your scenario. You have a 19-year-old female who goes to the public health department for STI testing. The patient tells the nurse practitioner that she was sexually assaulted 2 weeks ago, and she's worried she has an STI as a result. So the nurse practitioner does a pelvic exam and an STI test. So is a report to law enforcement mandated? So what we want folks to do is to type your answer in the question in the text box. So hopefully you're also with us. Yes or no, is a report to law enforcement mandated for this scenario? Okay, so we have 1, 2, 3, 4. Wow, okay, so several of you are responding, and so far everybody has the right answer, which is so exciting. So most of you who have, everybody who's responded said no. In this case, a report to law enforcement is not mandated by law for that nurse practitioner. And you are correct. Sorry. In this scenario, the nurse practitioner is not mandated to report to law enforcement, and there's two reasons for that. First of all, the nurse practitioner isn't a statutorily defined licensee. She was never covered by this law anyway. It was never applicable to her. Number two, as some folks said in your comments, there was no evidence collected. So what I think is really important, especially for folks to think, at the community, in your community, is that even though a report isn't mandated to law enforcement, it doesn't mean that the nurse practitioner should do nothing to address the sex assault. So we're going to talk a little bit more about that later in terms of resources, and I think that's something for hopefully you ought to think about a little bit in terms of, what resources and training can you give in your community to this nurse practitioner, so maybe she can talk to the patient about the sex assault. She can refer her appropriately. She can even talk to the patient about reporting options or put her in touch with an advocate who can explain reporting options. So we're not by any means saying the nurse practitioner should just ignore the sex assault, but we're just talking about what is mandated by law in this scenario. Okay, so the second scenario. So this is a 40-year-old man who presents at the emergency department of a hospital. So he has a concussion and bruising and states his partner caused the injuries. So he's seen by the ED physician. Upon the exam, the patient also discloses sex assault perpetrated by the partner. He's referred to as sane for a medical forensic exam. He wants evidence collected, but is unsure about proceeding with the criminal justice system. So this is a little bit more of a complicated scenario, but certainly something every one of us could see or hear about in our work. So this is a patient, again, concussion, bruising, discloses sex assault, wants a medical forensic exam, but also discloses that the person who inflicted these injuries is an intimate partner. So what has to be reported in this scenario? I jumped ahead. I gave the answers. Okay, so what are your thoughts on this? So people are saying yes. So we get the like this is a situation in which there are going to be some mandated reporting obligations. So folks, give us your thoughts about it. So what needs to be reported? Why does it need to be reported? So Terry, do you want to read some of the
Right,
comments?
we're getting the concussion and bruising has to be reported, not the sexual assault. Someone has said the report has to be done, but can be medical or anonymous due to the injuries and the admitted DV, which we're going to talk about here when we get to our answers. Most people seem to be saying the concussion bruising must be reported, but the SA can be anonymous or medical. That seems to be the general consensus.
Yeah, and I think you all, this is a sharp crowd. You all are totally getting it. Exactly. So again, this is a physician that is providing this care. And as we said, this statute that Senate Bill 128 addresses is applicable to physicians, certainly. So the physician is obligated to report the treatment of injuries. There's a concussion that's going to be treated, believed to be caused by a crime. There's a crime, domestic violence. So that's going to be reported. Because there's evidence collected, the sex assault will also be reported, but the patient still determines the type of report. So I think that's really important to know and think about. So what we would say with this type of case, yes, it is more complex. Yes, it requires some more sort of thought and analysis from responders. But that's important. I mean, we should be really thinking about how to respond in these cases. So, because the perpetrator is a partner, as we talked about, the patient should be advised of relevant domestic violence law. So you have the citation there. Colorado does have an arrest obligation for probable cause of domestic violence, and those domestic violence injuries are going to be reported. The patient can still elect, though, to have the sexual assault evidence stored anonymously, but that patient may be interviewed regarding the concussion and the domestic violence. So I know that this type of scenario can be really difficult, especially from a law enforcement perspective, because you probably feel like you're getting incomplete information. You know about the concussion, you know about the bruising and the domestic violence, but that sex assault evidence is technically anonymous. So what we would say about that is, if you have a patient who, for whatever reason, does not feel comfortable talking about the sex assault, wants anonymity on it, is not at a place where they can talk about the sex assault, honestly, our perspective is that should be respected. This is an adult patient and they don't want to talk about the sex assault, so we need to respect that. However, I think there's a lot of opportunities for a scenario like this. So, if law enforcement is interviewing this victim, then really there's a huge opportunity to build trust and to gain rapport. And we've done a lot of work. My office and Terry's office was studying converted cases. So cases in which a victim starts out saying, I don't want anything to do with the criminal justice system. I don't want to talk to the police. In Colorado, we have about a 20% conversion rate. Really without doing a whole lot, just sort of on their own, where a couple days later, the victim, they've gone home, they've ate, they've slept, they maybe thought about, some other options, they maybe learned about some other options, and they voluntarily decide, okay, now I do want to talk to law enforcement. Now I can think about the criminal justice system. So, just because and another thing I'll say about case conversions, the ones that we've studied in the state, case conversions tend to happen pretty quickly. Exactly like I said, typically it's a couple days out. Victim goes home, they eat, sleep, they talk to their family, and then they say, okay, I'm ready. I think the longest conversion we've ever seen in the state was 33 days. So that was like the outlier, and that's not even that long. So, this certainly could be a situation in which, yeah, maybe the victim does want anonymity in that moment, and they don't want to talk about the sex assault in that moment. If law enforcement is interviewing them about the concussion and the bruising, and if they're getting, responded to with comprehensive medical care and advocacy services, things could look different in a day or two where more information is given.
And just to tag on to that, with regard to converted cases, as Karen was saying, it's, I think, 56% convert within 72 hours and 66% convert within 10 days. So it is happening relatively soon if it's going to happen. Also, we have someone chiming in talking about the military, and that I'm assuming it's domestic violence for active duty personnel must be reported to military authorities. I think the point here is whatever circumstance you're in, because the military also has anonymous reporting options for sex assault. So it doesn't look dissimilar to the way Colorado state law is now set up, where we've got mandatory arrest on probable cause plus the mandatory report for domestic violence, but we've got the potential for anonymous report on a sex assault. And I think, as Karen said, it's just honoring the victim's choices on this. And frankly, victims self-select on this anyway. If they don't want to participate on the domestic violence or the sex assault, they just don't answer questions. I mean, they choose not to participate. So to reiterate what Karen said, I think this is, all we're doing is creating opportunities to build rapport with victims and set support systems in place and help victims understand what their choices and options are, and then letting them choose what works for them. So we're working on creating those opportunities.
And this is Karen again. I'll just say that I'm glad somebody brought up the military. That's, as Terry mentioned, the military actually, I would say, is one of a pioneering sort of entity around anonymous reporting. They've been offering, in the military, it's called restricted or unrestricted. So a restricted report is one that doesn't contain patient information. The military actually instituted that several years ago and really has seen a pretty remarkable increase in reporting rates once victims were offered that restricted or anonymous option. So, I thank you for bringing that up. Okay, not done with scenarios yet, though, even though you guys seem to be getting all of these, which is great. So the third scenario, this is a 72-year-old patient who presents at a hospital following a sexual assault that was perpetrated by her grandson's friend. She does not want law enforcement involved and doesn't want evidence collected, but she has significant vaginal bleeding and injury that require treatment. So can this patient obtain medical care without law enforcement being notified? So we want you to use your question box again. So you have the scenario on your screen. So yeah, what do you guys think? Can this patient obtain medical care without law enforcement being notified? So we have one person who responded, and they responded correctly. Okay, now you're all coming in. Okay, so I think for the most part, everybody got this correct. So yeah, I think it looks pretty good, although there's one clarification I want to make with this. So for this statute, for this scenario, because of various mandatory reporting statutes in Colorado, no, this patient cannot obtain medical care without law enforcement being notified. So we do have a separate statute that's a mandatory reporting obligation of elder abuse. The medical professional, and that's one thing that I do want to mention is the statute we've been working with under Senate Bill 128, it only applies to licensees, which we've discussed are physicians, physician's assistants, and anesthesiologist assistants. Our other mandatory reporting statutes, though, are broader. So in our elder abuse mandatory reporting statute, for example, nurses are mandatory reporters for all types of elder abuse. So that's just something to think about, too. Actually, all of our mandatory reporting statutes, who's a mandatory reporter, varies slightly. Like the elder abuse mandatory reporting list is not the same as the child abuse mandatory reporting list. So those are just things for you just to generally know. But because of the statute, no, law enforcement is going to be notified. If the patient does consent to evidence collection at some point, then she can still request to be a medical reporting victim, which means she doesn't have to participate in the criminal justice system, and certainly can receive that medical forensic exam at no cost to her. Anonymity is pretty challenging and really not possible for somebody that's covered under the elder statute, because those other mandatory reporting statutes for child abuse and elder abuse, and starting in 2016, the mandatory reporting obligation Colorado will have for people with intellectual and developmental disabilities, those statutes actually say that identifying information needs to be reported. So while this patient isn't going to be forced to participate with the criminal justice system, she probably will not be able to keep her anonymity because of the way the elder abuse mandatory reporting statute is constructed. So just to sort of throw a loop into this, so for a 72-year-old patient, we're pretty clear that a report's going to have to be made. But what if the patient is 69? So, in that sort of situation, if this patient was 69 years old, and we're not talking about the elder abuse statute, the treating physician, we know that physician is a licensee, they are still required to report treatment of injuries believed to be caused by a crime. So it's pretty tricky for that type of scenario where there are those other, specifically in this case, vaginal injuries. They're not technically required to report the sex assault, and the patient is not required to engage, but they are required to report treated injuries and injuries that are attended to. So somebody asked, sorry, what's the age again for elder? In Colorado, and specifically in regards to the mandated reporting statute for elder, it's 70 or above is the age. So for a 69-year-old, things would look different, frankly. But if there is a licensee who is treating injuries, those are still going to have to be reported. Yeah. Okay, so hopefully we're all clear on that. I'm not seeing any other questions about that one come in. So your last scenario, so this is a 34-year-old woman who presents at her neighborhood urgent care clinic, and she's seen by a physician. The patient wants STI and pregnancy testing as a result of a sexual assault that was perpetrated a month ago. Okay, so we had another question come up, and to clarify for licensee, yep, you're exactly right. A licensee is statutorily defined as a physician assistant, or an anesthesiologist assistant. That's who this statute applies to. Okay, so there's our scenario on the screen. So is there a mandatory reporting obligation? So a 34-year-old who sees a doctor, so they see a licensee, and they want STI and pregnancy testing as a result. They say that they were sexually assaulted a month ago, and her period's late, so they just want to, she just needs to make sure that she's not pregnant and doesn't have an STI. Okay, so you guys are answering, is there a mandatory reporting obligation? And everyone has gotten it correct. You guys are making my last day wonderful. It looks like most people totally have this. So in this situation, no, there's not a mandatory reporting obligation. Although the patient was seen by a licensee, a physician, there was no treatment for injury. There weren't injuries attended to. A pregnancy test is not treating an injury, and there was no evidence collection. So you guys got it exactly right. There's no evidence collection, no treatment for injury. So no mandatory report is mandated. And again, like I said earlier, it doesn't mean the physician should do nothing. Certainly, we would really want to see there be some specific conversations about addressing the sex assault, but they're not by law mandated to report it. So those are our scenarios. But I just wanted to say that, at the end of the day, in my nearly 6 years at CCASA, this was not the first bill I worked on around mandatory reporting. I actually worked on a few, and we get a lot of technical assistance questions around mandatory reporting. And it's the one thing, and I totally get it, people want very clear lines and rules. They give us a scenario and they say, tell me yes or no. And as folks who work with victims, we want to be able to give victims accurate information, about what's going to happen. So I totally get it. But the reality is the way that our statutes are constructed, they are always subject to interpretation, and there's always other policies and other statutes to consider. So it's just not always possible to have a black and white answer to mandatory reporting questions, especially because the way our statutes are constructed are around essentially that medical providers, or really that mandatory reporter's professional judgment, and what one person views as reportable may not be what another person views as reportable. And our statutes around mandatory reporting actually allow for that flexibility. They're very much written in terms of, what the provider thinks in their opinion, essentially. So I know that that's tough, and I know that it's not the way we like to do our work. But that's why I think it's really important for SARTs and communities to sort of look at these scenarios together and figure out, can we have sort of a collective interpretation of how we would address a patient, presenting with this type of issues or crimes. So I think Terry is going to kind of wrap it up for us.
Just a few things to remember. First of all, again, basically we've created two categories in the sex assault subsection. The first thing to remember is we didn't change the existing medical mandated reporting statute. All of the things that were required by licensees are still required. That's it. We pulled out, created a separate sex assault subsection, created two categories. We added nurses to that subsection since they weren't mandated by the original law, and then went from there. So, but we've got two categories. Evidence collection equals a report to law enforcement. One of three types, and which type of report is made is entirely determined by the victim. They're the sole determiner of that, as long as there aren't other statutes that apply. No evidence collection, no report is mandated. Again, people think this is new. It's actually not. We clarified it because our survey showed that there was tremendous confusion over this issue. And a lot of people who didn't need to be reporting were reporting, and a lot of people who weren't reporting should have been. So we're hoping we made this a little more clear. But if there's no evidence collection, there's no report. Again, unless there are other statutes that apply, or there are other injuries that require, attending or treating by a physician. So that is the basic construct of the statute, of the new statute. And then here's an easier way to remember this.
The questions.
It's a four-pronged test. And so you just work your way through these questions to determine whether or not a report is required. First question, is the medical provider a statutorily defined licensee? So ask that question and make a determination based on that. Go to the second question. Does the survivor have an injury that needs medical attending or treatment? That's your second question. If injuries are not being treated or attended to, there's no mandatory report. That's the way the law was written. That's the part that's been in existence for a long, long time. So we've gotten through the first two. The third question is, was evidence collected? And we just reviewed that. If evidence was collected, obviously a report, one of 3 types, victim chooses. If evidence is not collected, no report is required. So 3 questions. Your last question to ask yourself is, do other mandated reporting statutes apply? Or statuses, whichever.
Sorry, type it there.
So that's the simplest way we've come up with in answering all the questions we get, to kind of work through what's happening with the case in front of you relative to the existing statutes as they're written now with the new sex assault subsection. That's the easiest way to determine on its face what the basic legal reporting requirements are. Again, with the caveat that some entities, hospitals, and other places will have their own policies. So, but as far as the law is concerned, these 4 questions should get you to whether or not there's a report mandated.
Okay, so before we sort of end, I want folks to know that we get that this law, even though frankly we see it as a clarification from what was already there. It still does, because the clarification, it sort of changes things, because people really didn't have a great understanding of the law to begin with. So I know that this changes practice. It changes practice for law enforcement, it changes practice for medical providers, and it certainly changes practice for advocacy, when they're thinking about how to explain all this to patients. And I know that, because there are other statutes at play, it can be sort of difficult to flesh out. So, CCASA and both DCJ are really committed to making sure that folks have implementation tools and technical assistance for working this out in your communities. So I want to make sure that folks are aware of this website. It's just ccasa.org/reporting options. So that's really sort of a one-stop shop on CCASA's website for everything related to tools or resources that you may need for Senate Bill 128. On that website right now, you'll find that image that's in the center of the screen, the Colorado Sex Assault Evidence Collection Protocol. That's a document that was written by the Sex Assault Nurse Examiner Advisory Board. The 2015 edition is out, and it does address anonymous reporting and Senate Bill 128. So there's guidance within that document in terms of evidence storage, evidence labeling, that sort of thing. On the left of your screen, you'll see there's a brochure that CCASA has out. And this is a brochure that can be given to victims or patients that just explains reporting options, and hopefully a way that's easy for patients or victims to understand these different options. Something else that you'll see, as folks can imagine, since this is a change, we had to change sort of the consent forms that go inside of the rape kits in the state. So we had to create an anonymous reporting form. So you can print out those forms from our site. I know that CBI is who pays for and orders the rape kits for the state of Colorado primarily, and they certainly have these new forms, but there may be hospitals and clinics that have kits that are 2 years old sitting on their shelf, so they may not have the new forms in it yet. So that's something that we definitely need SARTs and folks at the community level to make sure you guys have the most recent consent forms that allow a victim to have an anonymous reporting option. So those can be printed off of our website and certainly used in your community. You'll see that really coming out this fall, CCASA, DCJ, and the Forensic Compliance team, we're putting out essentially a reporting options guidelines document. So it's going to be 20, 25 pages. We wanted to keep it at a length where people would actually read it, but it literally just walks through sort of best practices for each type of report. So what do we need to know about law and response for a law enforcement reporting victim, a medical reporting victim, an anonymous reporting victim, or a victim who's just getting medical care but doesn't want to engage in the criminal justice system? What do we need to know about relevant statutes for each of these populations, as well as some guidance in terms of how to respond. So that's something we're really excited about. So that will be on CCASA's website by this fall. I also put up there the link or the logo of Futures Without Violence. So I think that they have some great resources that I really hope folks are aware of in terms of this whole issue. We can train SANEs about this. We can train sort of our members, but it's a lot harder for us to train, public health departments and Planned Parenthoods and urgent care clinics or primary care physicians. And a lot of times, you know, victims will just go to wherever they feel most comfortable, and that could just be the urgent care clinic on their corner. So Futures Without Violence has an entire sort of training program around training medical professionals who are not in the sex assault field about sex assault, essentially. So if you go to their website, they have a guide specifically for OBGYNs about what to know and how to address DV and sex assault and within patient care. They also have a train the trainer curricula that any of you all could use with doctors or, you know, nurse practitioners or healthcare in your community about how to respond. And a lot of good really resources for medical providers. And I just think that's important because, you know, we have clarified that if a patient is not having evidence collected and they're not having injuries treated and they're not covered under other mandatory reporting statutes, that a report isn't mandated to law enforcement. And like I said, that doesn't mean that nothing happens. So I do think it's really important to look at all the great resources that are out there so that, you know, the primary care doctor on the corner does know how to refer a patient appropriately. So that's a great resource to take a look at what they have as well. So that is where we are. And as Terry said, this is my last day at CCASA, so I'm probably not going to be around to provide technical assistance, but CCASA is extremely vested in this work, and our Executive Director, Bree Akins, is available to provide technical assistance on this legislation. She came here from Oregon that had sort of a similar statute, and she's very familiar with Senate Bill 128. And then Terry is, of course, an incredible resource and can answer a lot of questions. And then keep an eye on our website because there will be more resources coming up. So thank you for spending your afternoon with us over your lunch hour, and best of luck with really implementing this in your communities. I feel really excited about the work and know that that it does make a really big difference to give victims choices and options. So thanks again.
Well, thank you, Karen. Thank you for sharing your last day with everybody and giving this great information. One more time before you leave CCASA, we're so sad to see you go. And thank you, Terry, for presenting as well. Some great information, and I can see that everybody was really engaged during this webinar, so that's awesome. Just a quick reminder, as soon as the webinar is over, there is an evaluation that we would love for you to all fill out. Your feedback is really important to us. Let us know what you think. Let us know what you want. We'd love to hear from you. I'd also just want to remind everybody that July 1st is the webinar that we're having, the Colorado Department of Public Health is putting on for us. It's called Using a Shared Risk and Protective Factor Framework to Leverage Resources, Partnerships, and Evaluation. Again, that's July 1st at 12 p.m. And also just want to plug our annual campus meeting, which is being held in Denver at Auraria campus on July 15th. If you have any questions, feel free to email any of us here at CCASA. You can email Terry, and I will send her any questions that anybody wasn't able to get an answer to during the webinar. Thank you so much, and please be sure to fill out the evaluation at the end. Thank you, and have a great day.